Yes, sir, we are live now.
Okay, thank you. Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals Limited. We at Emcure are proud to present Heart Failure Symposium, EARNI, Paradigm Shift in Heart Failure Treatment, our highly anticipated scientific program dedicated to exploring the multifaceted landscape of heart failure. I take this opportunity to extend a warm welcome to our international faculty, Professor John McMurray, sir, who has joined us all the way from Glasgow, Scotland, UK. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected by heart failure. Our distinguished international speaker, national moderator, expert panelists are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against this global health challenge. We are thankful to Professor John McMurray, sir, national moderator Dr. Subhash Chandra, sir, expert panelists Dr. Kamal Sharma, sir, Dr. Prashant Advani, sir, and esteemed moderators at the physical meeting at various locations who have generously decided to share their time and wisdom. Emcure is privileged to have a role in facilitating this bond. Let me have the privilege of introducing our esteemed faculty for this symposium. It is an honor to introduce our distinguished speaker for today, Professor John McMurray, sir, an internationally acclaimed physician and a renowned expert who has made significant contributions to clinical research and patient care worldwide. Professor McMurray is Professor of Medical Cardiology and Honorary Consultant. Professor of Medical Cardiology and Honorary Consultant at Queen Elizabeth University Hospital, Glasgow, Scotland, UK. He is past president of Heart Failure Association of the European Society of Cardiology. He is Congress Program Committee Chair for ESC 2023 and 2024. He is ESC board member. He is recipient of Rickshaw Spitalet International KFJ Award in 2021. He was awarded gold medal by ESC in 2020. He is awarded honorary OBE by Her Majesty the Queen in recognition of his services to cardiovascular research in 2019. He is clinical trial investigator of landmark trials, Paradigm HF, Paragon HF, DAPA HF, DAPA CKD, Deliver, Atmosphere, Harmony Outcomes, Galactif HF, Charm Added, Corona, Emphasis HF. He is member and former chair of several guideline committees. He is editorial board member for several journals, like European Journal of Heart Failure, Diabetes Care, and New England Journal of Medicine. He is also guest editor for Circulation Journal and Circulation Heart Failure Journal. Thank you for joining the meeting, sir. I take this opportunity to introduce our esteemed national moderator for today, Dr. Subhash Chandra, sir, whose insights and context-setting remarks will help us navigate the world of heart failure care effectively. Sir is chairman and head at Department of Cardiology, BLK Center for Cardiac Sciences, BLK Super Specialty Hospital at New Delhi. He has over 32 years of experience in cardiology, Interventional Medical Excellency Award, Current Economic Scenario in 2008, Chikitsa Bhushan Award by Delhi Medical Association in 2016 for Excellent Physician. He is recipient of Colonel K.L. Chopra Research Award in CSI 9th Annual Conference, recipient of Sujoy B. Roy Young Investigator Award in CSI 5th and 13th Annual Conference. He is faculty at various national and international conferences, including TCT, Euro PCR, TCT Asia Pacific, PCR Asia Pacific. He is principal investigator for various clinical trials. Sir has over 100 international and national publications in index journals to his credit. Thank you for joining, sir. I would also like to introduce and extend a warm welcome to our expert panelists whose knowledge and experience will help us in understanding practical aspects and Indian perspective on heart failure management. We have with us Dr. Kamal Sharma, sir. Sir is senior interventional cardiologist at UN Mehta Institute of Cardiology, Ahmedabad. He has vast experience in coronary angioplasty, valvuloplasty, pacemakers, and pediatric interventions. He is awarded 22 gold medals for academic excellence during medical studies. He is faculty in the Department of Cardiology at BJ Medical College, Ahmedabad. He has received awarded Excellence Teacher Award by Gujarat University. He discovered winking coronary sign of VSR on angiography, also called as Kamal Sharma sign of VSR. He is only cardiologist to have cleared civil services exam in first attempt. He is clinical trial investigator for landmark trials like SAV-HF, Atlas, TIMI, TIPS, Seraphine, Canvas, and he has over 205 publications and more than 8,500 Google Scholar citations to his credit. He is author of over 8 books and many book chapters. Thank you for joining, sir. We also have expert panelists for today, Dr. Prashant Advani, sir. Sir is Senior Consultant, Clinical and Preventive Cardiology at Advani Heartline and Metabolic Center, Raipur. He is Director at Advani Heart Clinic and Metabolic Center, Raipur. Sir is speaker at various national and international cardiac and cardiometabolic congresses. He has published research articles at various national and international index journals. He is passionate about disseminating current medical knowledge amongst medical professionals through seminars, CMEs, ad boards, and conferences. Thank you for joining, sir. I would also like to introduce and extend a warm welcome to our esteemed moderators who are participating in this physical meeting at various locations. We have with us from Chennai, Dr. S. Manoj, sir, interventional cardiologist at Kaveri Hospital. From Mumbai, we have Dr. Suhas Desai, sir. Sir is Director Consultant Cardiologist at Ayush Hospital. From Madurai, we have Professor Dr. G. Selvarani, ma'am. Ma'am is Professor of Cardiology at Madurai Medical College. From Surat, we have Dr. Dhaval Shah, sir. Sir is Consultant Interventional Cardiologist in Iconic Heart Clinic. From Trichy, we have Dr. Ganesh, sir. Sir is Consultant Interventional Cardiologist at GG Specialty Clinic. Thank you for joining today's meeting. And finally, I would like to extend a special welcome to all the delegates who have joined today's program at physical locations and on virtual platform. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our national moderator, Dr. Subhash Chandra, sir. The meeting will proceed further with the keynote lecture on ARNI, a paradigm shift in heart failure treatment by Professor John McMurray, sir. Following this, we'll have a quick comments by national moderator on the lecture and 15 minutes panel discussion where all the faculty members will participate. Then we'll have a Q&A session with faculty members where moderators at physical locations will ask questions on behalf of the audience. Post the discussion, we'll have a concluding remarks by our esteemed national moderator. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of heart failure. I request our national moderator, Dr. Subhash Chandra, sir, to share his opening remarks on today's topic. Over to you, sir.
Thank you, Doctor. So that was really comprehensive, and I'm sure all of us feel humbled by our extensive introduction which you've given. In fact, Dr. McMurray pointed out that don't read out my full CV. And needless to say that everybody knows him. So today we are privileged here.
Dr. Rishikesh seems we lost him for a connection, so I think we can start. Yeah.
Okay.
Do you hear me? Hear me?
Yes, sir. We can hear
it's coming
you.
up.
Sorry, so there was some internet glitch. So with that, let's kick start. We are here to listen to Professor McMurray on the management of heart failure. And you know, in our own country, where the mortality figures hover at almost 50% plus at the end of 5 years, which is much more than any cancer, we are truly worried. And we have been struggling with this art of managing heart failure in last decade or so, where we are fortunate to have witnessed the emergence of some of the key molecules, and in which ARNI is one molecule which stands out because it acts on two simultaneous mechanisms of heart failure mediated problems or remodeling in the heart. So without much ado, I would invite Professor McMurray to start his presentation, and thereafter I will seek assistance from my national colleagues who are sitting at various corners to coordinate this activity so that most of us are benefited by his lecture. Thank you so much. Professor McMurray, the floor is yours. Please upload your slides.
Thank you very much, Dr. Chandra. So I'm going to attempt to share my screen. So I hope that
Yes, sir.
people can now see my slides.
We can.
Oh, excuse me. And I'm just going to set my pointer up so that I can point to things. Okay, well, thank you very much indeed for all the kind introductions, and thank you very much indeed for spending your Friday evening listening to this presentation. I really do appreciate that. I hope I can make it interesting. So I'm going to talk about sacubitril valsartan, which is presently the one and only angiotensin receptor neprilysin inhibitor available to us to treat patients with heart failure. And these are my disclosures. So I want to start about saying how we got here. Why did we want to develop a drug like this? Why did we think it would be useful in our patients with heart failure? And of course, the whole story really begins with the discovery when I was a young trainee by an Argentinian scientist living and working in Canada that the heart was more than just a mechanical pump, but is actually an endocrine organ. And the heart, and we now know also the blood vessels and the kidneys, produce peptides that we call natriuretic peptides, which are really the way that the body defends itself against pressure and volume overloads. And we realized that this endogenous system, if we could harness it, enhance it, exploit it, might be a way to improve patients with heart failure. And the way eventually we discovered this could be done was by inhibiting the enzyme responsible for the breakdown of natriuretic peptides, and this enzyme is called neprilysin. Now, as I'll come back to later, this enzyme has a lot of other substrates which actually may be also very important in the way that neprilysin inhibitors help. But the rationale behind the development of sacubitril valsartan and indeed other drugs was to inhibit the breakdown of natriuretic peptides, enhance the amount of these peptides in the blood and in the tissues. These are vasodilators. They inhibit pathological growth. They suppress the renin-angiotensin system and sympathetic nervous system. They augment the parasympathetic nervous system. They have a whole range of actions that we believe should be beneficial in patients with heart failure. It took about 25 years to figure out how to use neprilysin inhibitors safely in patients with heart failure, and that turned out to be in combination with an angiotensin receptor blocker. So, as was pointed out in the introduction, it's very important to remember that these are really two drugs combined in a single pill. And the pivotal trial that we conducted demonstrating the value of adding a neprilysin inhibitor to a renin-angiotensin system inhibitor was the Paradigm heart failure trial, which we published in 2014. And essentially, this was a trial testing the addition of a neprilysin inhibitor on top of what at that time was conventional therapy, a beta blocker and a mineralocorticoid receptor antagonist versus conventional therapy alone. And as you can see in Paradigm, the vast majority of patients were treated with a beta blocker. About half of them were treated by an MRA. And because, of course, this was a comparison of sacubitril valsartan to enalapril, everybody was getting a renin-angiotensin system blocker. And this is the result of the paradigm heart failure trial. So in these patients with heart failure and reduced ejection fraction and predominantly mild symptoms, you can see that adding an neprilysin inhibitor to conventional therapy reduced the risk of cardiovascular death or heart failure hospitalization. That was the primary composite endpoint in the paradigm heart failure trial. That endpoint was reduced by 20%. So hazard ratio was 0.80, 20% relative risk reduction. This was highly statistically significant, a very, very robust finding reflecting the considerable efficacy of the treatment and the very large trial. This was a trial of approximately 8,400 patients. At that time, it was by far the biggest ever trial in patients with heart failure. And each of the components of that composite endpoint was reduced significantly by about 20%, both cardiovascular death individually and heart failure hospitalization individually. So very powerful evidence that inhibiting neprilysin was of incremental therapeutic benefit over and above doing the other things that we knew were beneficial in patients with heart failure and reduced ejection fraction. And not only was cardiovascular death reduced by 20%, but as you can see, the two major modes of cardiovascular death in patients with heart failure, which of course are sudden death and death due to worsening heart failure or pump failure, each of these was also reduced by about 20%. So this treatment was reducing both sudden death and pump failure death. And there was also a reduction in overall mortality. That is the hardest thing to show with any treatment in any cardiovascular condition. But in paradigm heart failure, there was a significant 16% relative risk reduction in all-cause mortality. That translated into an estimated number needed to treat over 5 years of 14. And across all the different subgroups that we looked at in paradigm heart failure, younger people, older people, higher, lower ejection fraction, kidney dysfunction, etc., that number needed to treat ranged between 12 and 19. And those, of course, are very small numbers needed to treat. And again, this figure puts that benefit into context. And maybe the most interesting thing here at the bottom is comparing sacubitril valsartan to what's called an imputed placebo. So we had compared sacubitril valsartan to enalapril. Enalapril, of course, had been compared to placebo in the SAV treatment trial. So we were indirectly able to compare sacubitril valsartan to an imputed placebo, and the number needed to treat to prevent one death from any cause over 5 years was only 11 in this calculation. But it wasn't just death and cardiovascular death and heart failure hospitalization that was reduced, but also there was an improvement in symptoms and quality of life. And we've published a lot of this in detail, and this is one of the interesting analyses I think we saw in our investigation of health-related quality of life. This shows you the difference between sacubitril valsartan and enalapril over the first 8 months after randomization. And what you see here are different questions in the Kansas City Cardiomyopathy Questionnaire looking at physical and social limitations. And the higher each of these green bars, the larger the difference in favor of sacubitril valsartan over enalapril. In other words, the larger the difference made by neprilysin inhibition. And you can see that for all of these different activities that the patient was asked about in this questionnaire, which of course was administered in a completely blinded way, you can see that there was an improvement with sacubitril valsartan compared to enalapril. So reduction in mortality, reduction in heart failure hospitalization, improvement in symptoms and in quality of life, really all of the goals of therapy in patients with heart failure and reduced ejection fraction. Really, that's just summarized here on this slide. Now, of course, that trial was conducted, as I mentioned, in predominantly patients with predominantly mild symptoms, and all of these patients were ambulatory or outpatients. We did not enroll hospitalized patients. And that's why this second smaller trial, which was published 5 years later, is important, because this is a trial that was carried out in patients who had been admitted to hospital with worsening heart failure. This trial was called Pioneer. It was a smaller and it was a shorter term trial, but there were some very important differences in the design of this study that are relevant to the way that we can use this treatment in clinical practice. So as I said, all of the patients who were enrolled in this trial were randomized when they were in hospital. They could be randomized after 24 hours from admission. The median time to randomization was 68 hours. The key criteria to be enrolled in this trial was to have a systolic blood pressure more than 100 millimeters of mercury, to be off intravenous therapy. And of course, these patients also had reduced ejection fraction. They had elevated natriuretic peptides. And as in the Paradigm trial, patients had to have preserved kidney function, so an eGFR of at least 30 mils per minute. And they also had to have a normal potassium, as you can see here, potassium of 5.2 millimoles per liter or less. Now, this was a small study of around 900 patients, so the primary outcome was a biomarker outcome, and that was NT-proBNP, so the inactive fragment of BNP. So as you know, BNP is secreted predominantly by the ventricular myocardium in response to wall stress. So reduction in NT-proBNP reflects a reduction in left ventricular wall stress. It was a short-term trial, so patients were randomized to sacubitril valsartan or enalapril for 8 weeks. The reason it did not go beyond 8 weeks was because it was felt unethical to deny patients sacubitril valsartan beyond that period, because really by that stage they were becoming paradigm-like patients, and we know that sacubitril valsartan is superior to enalapril in patients who have been discharged from hospital, who are outpatients in the community. So that is why it was a short-term trial. It had no active run-in period. Patients did not have to be on a ACE inhibitor or angiotensin receptor blocker to be included. And here you can see the baseline characteristics. So the average age, as you can see, was in the early 60s. Between a quarter and a third of patients were women. A lot of patients in this trial were of African descent. It was conducted only in the United States. And as you can see here, a third of patients had no previous history of heart failure, and more than half of patients were not on prior renin-angiotensin system blocking treatment. So very important groups of patients who we had not included in the Paradigm heart failure trial. You can see that the average baseline systolic blood pressure here was 118 millimeters of mercury. So this is the primary endpoint. It's reduction in NT-proBNP. This was reduced more by sacubitril valsartan compared to enalapril. And I think the key thing we learned in this trial was just how quickly that benefit is observed. You can see that within 1 week of starting treatment, there was a significant reduction in NT-proBNP. There was a significant reduction in left ventricular wall stress when an neprilysin inhibitor was given on top of a renin-angiotensin system blocker compared to a renin-angiotensin system blocker alone. And that reduction in NT-proBNP was sustained for the full 8 weeks of treatment. Now, the other important difference between this trial and Paradigm was that patients were not required to be on the full dose of therapy before randomization. Patients were started on a low dose of sacubitril valsartan or enalapril in a blinded fashion. They had treatment up titrated as far as could be tolerated. And as you can see here, not everybody managed to reach the target dose. Just over half of patients reached the target dose of these two treatments. But you can see even with this, there was a clear difference between enalapril and sacubitril valsartan. You can also see the tolerability here. So worsening kidney function, of course, occurs in patients with heart failure, but it was not more common in patients getting sacubitril valsartan. I'll come back to that later, nor was hyperkalemia. In fact, the only adverse effect that was a bit more common was symptomatic hypotension. And again, I'll come back to that later, because this really is the single biggest challenge with using sacubitril valsartan in practice compared to RAS blockers by themselves. And angioedema, which we had been worried about with sacubitril valsartan because neprilysin is responsible for breaking down bradykinin, as it turns out, in none of the trials we've conducted has angioedema turned out to be a frequent adverse effect. But the really, really surprising and interesting finding in this small study of around 900 patients was that the exploratory clinical composite outcome that was pre-specified was also reduced significantly by sacubitril valsartan compared to enalapril. And this, of course, was over a period, as I said, of just 8 weeks of treatment. So even with this relatively small number of patients and this relatively short-term treatment, there was a substantial and significant reduction in a clinical endpoint, although this was driven predominantly by the risk of heart failure rehospitalization in this particular population. Now, maybe it shouldn't have been a surprise because we had seen in Paradigm that there was a significant benefit within just 30 days of randomization in our much bigger trial, but it was good to see that early benefit replicated in this smaller trial. So because of this evidence for patients with heart failure and reduced ejection fraction, sacubitril valsartan is now considered one of our foundational treatments for heart failure, although I want to keep emphasizing that this, don't forget, is actually two different types of treatment. So although our foundational therapies are pillars of treatment for heart failure with reduced ejection fraction, is currently these 4 different pills, there are in fact 5 distinct pharmacological entities here. There is RAS blockade, neprilysin inhibition, and then, of course, beta blockers and mineralocorticoid receptor antagonists. And the most recent addition to this key group of therapies that reduce mortality in patients with heart failure, of course, are the SGLT2 inhibitors. So 4 pills, but 5 different therapies. So whether you prefer 5 alive or Fantastic Four, this is what we talk about today. And in the guidelines, of course, sacubitril/valsartan, as a result of those trials, has a class 1 recommendation and has the strongest possible recommendation for the treatment of heart failure with reduced ejection fraction. Now, I said I would come back to hypotension, and I've given a few talks to groups of doctors in India recently, and one of the questions that keeps coming up is about blood pressure and the concern that many physicians have about low blood pressure and the fact that sacubitril/valsartan does reduce blood pressure. There's no question about that, more than an ACE inhibitor or an angiotensin receptor blocker by itself. So nobody else has seen these data. They have literally just been analyzed in the past few days. And what I did was I got one of my fellows who's visiting from Japan to work on the Paradigm Heart Failure Database and to look at outcomes in patients who developed either symptoms of hypotension, so dizziness, lightheadedness, or patients who developed a low blood pressure but didn't have symptoms. And by low blood pressure, hypotension, asymptomatic hypotension, here I mean a systolic blood pressure of less than 100 millimeters of mercury after randomization. Now, this looks like a fairly complicated figure, but it is crucially important, and I will try and walk you through it carefully. So this first line here shows you patients who developed symptoms of hypotension after being randomized to enalapril, and this figure is for all-cause mortality. And you can see here the y-axis scale is from 0 to 40%, and the follow-up period here is 3 years. Now, you heard mentioned in the introduction how fatal heart failure is, and you can see here very clearly that that is indeed the case. But you will note here that this group of patients with the highest rate of all-cause mortality are patients who developed symptoms of hypotension after randomization to enalapril. The corresponding patients who were randomized to sacubitril/valsartan are shown by this line. So here are the patients who developed symptoms of hypotension when on sacubitril/valsartan. And you can see that they had a much lower risk of death than patients developing hypotension on enalapril. We know that hypotension is not a good thing in heart failure, but you can see that it is a very different problem if you're treated with enalapril and sacubitril/valsartan. The next line here, the group of patients at next highest risk, the second highest risk group of patients, are individuals who developed hypotension without symptoms, so had a systolic blood pressure of less than 100 millimeters of mercury, who were randomized to enalapril. And the corresponding group, of course, who got sacubitril/valsartan are shown by this line just below. So again, a lower risk if you were randomized to sacubitril/valsartan than if you were randomized to enalapril. And finally, at the bottom here are patients who did not experience hypotension after randomization during follow-up in Paradigm. But once again, patients randomized to sacubitril valsartan did better than patients randomized to enalapril. So yes, having hypotension isn't good, but it's much better to be on sacubitril valsartan than on enalapril, whether you have symptomatic hypotension, asymptomatic hypotension, or no hypotension. So let's switch gears completely and look at the remainder of patients with heart failure. In other words, patients with heart failure and mildly reduced or preserved ejection fraction. And we did a second large randomized trial in those individuals. That trial was called Paragon Heart Failure. It was a much smaller trial, around 4,800 patients. These patients all had an ejection fraction of 45% or above. And the comparator in this trial was valsartan and not sacubitril valsartan, valsartan and not enalapril, because we were not obliged by the regulators or by ethics committees to use an ACE inhibitor in these patients because there was no good evidence to choose an ACE inhibitor over an angiotensin receptor blocker in patients with heart failure and an ejection fraction above 40%. So sacubitril valsartan compared to valsartan. We had a slightly different endpoint. It was still cardiovascular death and heart failure hospitalization, but in this trial, we looked at the total number of events rather than the usual time to first event. Here is the result of Paragon heart failure for the primary endpoint, and you can see that although the event rate was lower in patients who got sacubitril valsartan compared to valsartan, the difference was not statistically significant. There was a 13% relative risk reduction, but the upper 95% confidence interval around the rate ratio was just over 1, and the p-value was just greater than 0.05. So this was not an overall significant benefit. Very different than we saw in heart failure with reduced ejection fraction. But what was interesting was that amongst the pre-specified subgroups that we said we would analyze before we knew the results of the trial, there was one striking significant interaction, and that was between ejection fraction and the effect of sacubitril valsartan versus valsartan. And what we found was that patients who had an ejection fraction at or below the median value of 57% seemed to get benefit. This equates to a 22% relative risk reduction. Patients with an ejection fraction above the median value of 57% did not seem to benefit. This was the pre-specified subgroup analysis. Now, there is another way of looking at this that is more statistically powerful, and that's to look at a continuous hazard ratio using ejection fraction as a continuous variable. So this is now Paradigm and Paragon combined. So we have almost 13,500 patients across the whole spectrum of ejection fraction. The solid blue line shows you a continuous hazard ratio. The shaded blue area are the 95% confidence intervals. The black horizontal line is a hazard ratio of 1. And if the hazard ratio here is below 1, that indicates benefit of sacubitril valsartan. And you can see again in this analysis that the hazard ratio is consistently below 1 up to an ejection fraction somewhere between 55 and 60%. In other words, this analysis suggests that sacubitril valsartan is beneficial in patients with an ejection fraction above 40% and probably has benefit in patients who essentially have an ejection fraction that is below normal, which is about 55% in men, maybe a bit higher in women. And there is now some very recent evidence to add support to that conclusion. This is another smaller trial. This is like the sister trial to the Pioneer heart failure trial. This is a trial looking at patients with recently decompensated heart failure who had an ejection fraction above 40%. Most of these patients had been admitted to hospital with worsening heart failure. Again, this was a relatively small trial with the same primary endpoint as in the Pioneer heart failure trial, reduction in NT-proBNP. But of course, because this trial was done or had started when we discovered the results of the Paragon heart failure trial, there was a pre-specified subgroup analysis looking at people with an ejection fraction divided at 60%. So here is the overall population. There was a significant reduction in NT-proBNP. It wasn't as large as seen in the Pioneer heart failure trial amongst these patients with mildly reduced and preserved ejection fraction, but it was a significant reduction. But what was, I think, very interesting was to look at that pre-specified subgroup analysis. So over here to the left, this panel shows the patients who had an ejection fraction between 40 and 60%. These patients had a clear, significant, and larger reduction in NT-proBNP. These patients with an ejection fraction above 60% had no significant reduction in NT-proBNP. And there was a significant interaction between ejection fraction subgroup and the effective therapy. So this really fits with the interpretation that we had made of the Paragon heart failure results, and indeed the one that had led the US Food and Drug Administration and various other regulatory agencies to approve the use of sacubitril valsartan in at least some patients with heart failure and an ejection fraction above 40%. So we also had pre-specified before we'd seen the results of the Paraglide heart failure trial that we would combine that trial with Paragon heart failure, and of course that we would do a subgroup analysis in patients with an ejection fraction of 60% or less. So here is the main analysis, which was patients in Paraglide combined with Paraglide-like patients in the Paragon heart failure trial. So we had a fairly large number, over 800 patients who were like the patients in Paraglide in Paragon. So you can see those two trials combined here. Overall, there was a significant reduction in total worsening heart failure events and cardiovascular deaths. And again, there was a significant interaction when we did the pre-specified subgroup analysis by left ventricular ejection fraction split at 60%. And if you look at now the overall population of the two trials, so that's now more than 5,000 patients, again, you can see the subgroup interaction here showing benefit in patients with an ejection fraction of 60% or less, but no benefit in patients with an ejection fraction above 60%. So again, we think more evidence supporting the view that sacubitril valsartan is beneficial in patients with an ejection fraction above 40%, perhaps up to 60%. And that's why the US guidelines, the US regulatory agency, the Food and Drug Administration, and the regulatory agencies in many other countries now have expanded the indication for sacubitril valsartan to include patients with an ejection fraction above 40%. So while we have evidence that MRAs and beta blockers are beneficial, perhaps up to an ejection fraction of 50%, there is evidence that sacubitril valsartan perhaps benefits patients to an even higher ejection fraction. And of course, the drug that is beneficial across the whole spectrum of ejection fraction, the drug class beneficial across the whole spectrum of ejection fraction, are the SGLT2 inhibitors. So I'm now going to finish up with just showing you quickly some other, I think, interesting additional information that we've been able to mine from these very large clinical trials over the past few years. I can't show you everything. There's been a huge explosion of publications about neprilysin inhibition in patients with heart failure, but I'll pick out some of the more interesting ones. So first, I'm going to look at kidney function. We've published 2 and recently a third, I think, important papers showing that sacubitril valsartan slows the rate of deterioration in kidney function over time. So this is the Paradigm heart failure trial. These are patients without diabetes, patients with diabetes. This is change in eGFR over time, as you might expect. In all patients with heart failure, eGFR decreases, as you can see, over the 3 years of follow-up here, but that decrease is steeper, greater in patients with heart failure, reduced ejection fraction who've got diabetes compared to those without diabetes. And what you can see if you look at the 2 lines in a fainter, lighter color, you can see that the rate of decline is less in patients getting sacubitril valsartan compared to patients getting enalapril. And these differences are statistically significant. So adding a neprilysin inhibitor slows the rate of decline in eGFR over time. But when we got the Paragon heart failure trial, we were able to combine our 2 trials to look at a conventional kidney endpoint. So this is the endpoint used in kidney disease trials. So it includes patients who have a sustained large reduction in eGFR, people who develop end-stage kidney disease, meaning going on dialysis, having a transplantation, or having an eGFR that is below 15 mils per minute and sustained at that level, or patients who die from kidney failure. And if you look at that endpoint in our 2 large trials combined, you can see that it is substantially and significantly less common in patients getting sacubitril valsartan compared to patients getting a RAS inhibitor alone. This equates to a 44% relative risk reduction. This is as big a decrease in kidney endpoints as we see, for example, with SGLT2 inhibitors. So this is a very important additional benefit of sacubitril valsartan, of neprilysin inhibition in patients with heart failure, be that heart failure with reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction. Another benefit is the reduction in hyperuricemia and gout. And just to maybe remind you, uric acid levels are a very powerful predictor of outcome in patients with heart failure. If your patient with heart failure has a high uric acid level, that is an independent predictor that that patient is at much higher risk of both death and heart failure hospitalization. Sacubitril valsartan, neprilysin inhibitor, reduces uric acid levels compared to, here you can see enalapril. We saw exactly the same thing in Paragon, reduction in uric acid level compared to valsartan, and maybe of more clinical relevance from a practical point of view is that that reduction in uric acid level is also associated with a reduced use of uric acid reducing therapies such as xanthine oxidase inhibitors, and even in colchicine, which is obviously given to treat acute attacks of gout. So sacubitril valsartan not only has a biochemical benefit, but actually also reduces the need for other uric acid lowering therapies, and we believe in attacks of gout. Another ancillary benefit of neprilysin inhibition is improvement in glycemic control, and this is where those other substrates for neprilysin may be important, because one of them is glucagon-like peptide 1. So as you know, dipeptyl peptidase 4, DPP4, also breaks down GLP-1. We use DPP4 inhibitors to treat type 2 diabetes, to lower glucose. Of course, we use GLP-1 receptor agonists as well. Sacubitril valsartan increases GLP-1. We've seen this in our own trials. This is another group demonstrating the same thing, that neprilysin inhibition in humans increases GLP-1. And we think this is one of the likely explanations for a finding we reported a few years ago in Paradigm, showing that compared to enalapril, sacubitril valsartan significantly reduced hemoglobin A1C levels in HFrEF patients with diabetes, and that was also associated with a large and significant reduction in the likelihood of patients being started on new insulin therapy during the blinded follow-up in the trial. You can see here that patients getting sacubitril valsartan were about 30% less likely than patients getting enalapril, shown in red, to be started on new insulin treatment. And that is a very desirable thing in patients with heart failure. And you can see that we were able to reproduce these findings in the Paragon heart failure trial, where the comparator, as I mentioned, was valsartan and not enalapril. And then finally, the last of the new findings showing the additional benefits of neprilysin inhibition relate to hemoglobin and anemia. And again, we believe that these are due to one of the other effects of neprilysin inhibition, because it breaks down substance P. So another substrate for neprilysin inhibition is substance P, and substance P stimulates hematopoiesis, and in fact, one of its breakdown products is an inhibitor of hematopoiesis. So we believe that if you inhibit neprilysin, you will reduce the tonic inhibition on hematopoiesis. And in fact, you can see here that if you look at change in hemoglobin over time, then patients treated with sacubitril valsartan in the Paradigm heart failure trial had a slower rate of decline in hemoglobin over time compared to patients treated with enalapril, shown in blue here, who had a steeper decrease in hemoglobin over time. And again, this reflects what we all know, that as heart failure progresses, then hemoglobin tends to decline. And in fact, if you look at the development of new onset anemia during follow-up in the Paradigm heart failure trial, at 1 and 2 years here, you can see a large and statistically significant reduction in the risk of new anemia in the sacubitril valsartan group compared to the enalapril group. And again, we were able to reproduce these findings in the Paragon heart failure trial, where the comparator was valsartan as opposed to enalapril. So again, we think these findings are very robust because we were able to demonstrate them in 2 trials. So I'm going to stop here because I have not got time to go through all the other interesting findings that we've made about sacubitril/valsartan. In particular, others have shown favorable cardiac remodeling, and we've shown that, in fact, there are improved biomarkers reflecting fibrosis and even troponin in patients receiving sacubitril/valsartan compared to a RAS blocker by itself. So again, all consistent evidence that the structure and function of the heart is improved, consistent with those improved outcomes. We recently confirmed a reduction in ventricular arrhythmias, consistent with that reduction in sudden cardiac death that I mentioned earlier, told you about glycemic control, anemia, and uric acid levels. There's also a significant reduction in hyperkalemia and a reduced risk of hyponatremia and hypochloremia in patients receiving sacubitril/valsartan compared to a RAS blocker alone. So to summarize, these 2 treatments combined in 1 pill are really very valuable, and that the new treatment in this combination therapy, the neprilysin inhibitor, has all of these additional cardiovascular benefits that, of course, are crucial, but also these additional renal, metabolic, and hematological benefits that I've told you about. And we really do believe that this is generally a well-tolerated treatment. In fact, causes less renal dysfunction, less hyperkalemia than RAS blockers by themselves. Angioedema is rare. Hypotension is a bit more common, but actually patients who have hypotension on sacubitril/valsartan do much better than patients who have hypotension on a conventional RAS blocker by itself. So with that, I'd like to thank you very much indeed for listening.
Thanks, Professor John McMurray. It was wonderful elucidation of many new discoveries which have been churned out of your presentation, where beyond simple HFrEF, we come to know about that what role it has played in the HFpEF area. And there's a hope that when you dissected the trial in tandem with the Paraglide, there was a definite hope that yes, even in HFpEF, the drug is working wonders. And beyond heart failure, you have shown us in different other areas where there's a very convincing evidence that it has a role to play, ranging right from the arrhythmia control to right ventricular dysfunction in primary pulmonary hypertension. And we know for sure in arrhythmia control, there is data that if you put this drug in a heart failure patient, there's bound to be reduction in the requirement for implantation of ICDs or CRTs. Even heart failure patients have been pulled down from the heart transplant list or LVAD list. So there's ample evidence to that effect. My query is regarding 2 major areas. One, in advanced heart failure. In heart failure, which is class 4, as was the evidence in one of the trial, which is LIFE trial. And I want to understand from your good self that what are your views in those patients who have very advanced heart failure, and the hemodynamics is very intricate to tolerate this drug. How would we go in that area? And before I forget, the next part will be about acute myocardial infarction and post-myocardial infarction LV dysfunction. So floor is yours. Please enlighten us on those 2 areas.
Okay, so of course, so thank you very much for the comments. So, and 2 great questions. So the LIFE trial, of course, was a very small trial. It was about 460 patients. And it was also a trial that had great problems related to the COVID-19 pandemic. So it's actually quite difficult to interpret. And at the end of the day, only, I think it was 335 patients had analyzable data, and the trial lasted 6 weeks. The primary endpoint, of course, was reduction in NT-proBNP, and by and large, NT-proBNP was reduced by sacubitril/valsartan compared to valsartan, as you would expect. But I think the thing that attracted a lot of attention was that there was no suggestion of a better outcome. And in fact, in the small number of events that occurred were slightly more common. A small number of adverse events that occurred were slightly more common in the sacubitril/valsartan treated patients than in the valsartan treated patients. So how do you interpret all of that? Well, I think large trials always trump smaller trials, and we actually had far more patients with class 3 and 4 heart failure in the Paradigm heart failure trial than were included in the LIFE trial. And if you look at the class 3 and 4 patients together in Paradigm, they did better with sacubitril/valsartan than with enalapril. Now, for full disclosure, we didn't have many class 4 patients, and I do think there probably is a question about class 4 patients, because we simply, neither in the LIFE trial nor in the Paradigm heart failure trial, have enough of those patients to robustly assess the effect of treatment. But I think it's very unlikely, and it would almost be unheard of, for a treatment to be beneficial in the vast majority of patients with heart failure who are not class 4, who don't have very advanced heart failure, but then to be detrimental or harmful in class 4 patients. You don't see that completely qualitatively different effect of treatment. And, you know, there are good examples of that. For example, the consensus trial with enalapril was in very sick patients, and that trial showed benefit of treatment. Subsequent, much larger trial in patients with milder treatment confirmed benefit. Same was true for mineralocorticoid receptor antagonists, the RALS trial and the Emphasis heart failure trial. So it's hard to believe that there's a qualitatively different effect of sacubitril/valsartan in class 4 patients versus patients in class 2 and 3. But we do not have specific strong evidence in class 4 patients. So I think basically you have to try and use sacubitril/valsartan cautiously in those individuals. And your second question was about acute myocardial infarction. Well, we did do a trial in acute myocardial infarction. That trial was called Paradise-MI. That was not a positive trial. And therefore, I would say don't use sacubitril/valsartan routinely after myocardial infarction. I believe in practicing evidence-based medicine. The evidence is that sacubitril/valsartan is very good in patients with established heart failure, particularly established heart failure and reduced ejection fraction. We did not include in Paradigm heart failure patients who were within 3 months of a myocardial infarction. So I suppose what you could say is that 3 months after your patient has their myocardial infarction, if they have heart failure, they have transitioned from being a Paradise-MI patient to being a Paradigm heart failure patient. And that is when you could very legitimately, of course, choose to switch them to sacubitril/valsartan if you've used an ACE inhibitor or angiotensin receptor blocker after myocardial infarction. So those would be my 2 answers.
And in the first question, what worries me and leaves me inquisitive is that even in Victoria trial on Vericiguat, we witnessed that in the very advanced heart failure population where NT-proBNPs were in a very high range, there was not much benefit. And so I was wondering whether the same sequence is replicated in both these trials, although you elucidated in detail as to why it should not work in class 4 patients also. So that is what triggered this question in my mind. But you have nicely elucidated that
Well,
yes.
I can go one further. I can tell you that we have done that analysis looking across the range of natriuretic peptide levels that we have, obviously, in paradigm heart failure, and we do not see any suggestion that there is reduced benefit in patients with a high natriuretic peptide. Now, admittedly, the upper 99 percentile, if I remember it correctly, was 10,000 picograms per mil in paradigm heart failure. So I think maybe the levels went a bit higher in Victoria, but that's a pretty impressive natriuretic peptide level, NT-proBNP level, and we did not see any hint, any attenuation of benefit of sacubitril valsartan across the range of natriuretic peptides. So the Victoria and vericiguat, I think, are a whole different question. I mean, the overall benefit of vericiguat was extremely modest. There was no reduction in mortality. If we look at very sick patients in paradigm, and we had some very sick patients in paradigm, then we see just as much benefit. And if I was giving you another talk, I would actually make the point that the way that we talk about risk is much too simplistic, because our brains can't work out risk, which is a multivariable concept. We think about class 4 versus class 3. We think about high blood pressure versus low blood pressure. We think about low eGFR versus high GFR. Risk is not like that. It is a multivariable construct. And if you look at high-risk patients using a predictive model, then in paradigm heart failure, we had many of those high-risk patients, and they got very large benefits from sacubitril valsartan. So sacubitril valsartan is very different than vericiguat. I really think that they're completely different drugs with a completely different efficacy profile.
So, that's very nice. So if I could just invite some of my other esteemed panelists who are here, and people from different regions, if they have any queries, please come forward and ask Dr. McMurray your questions.
Dr. Subhash, may I? Dr. Advani?
Please.
Thanks, sir. So the one query you already addressed, life and what didn't work in life study and Paradise MI. Another one, in the practical scenario in India, we see paradigm HF type of patients are in very young age, in 33, 34, in early 30s and early 40s, late 20s, with a very established heart failure. Most of it is ischemic. Prior revascularizations have happened, and those guys are the ejection fraction hovering around 20 to 40% in various functional class 2, 3, ambulatory class 4. And there's systolic blood pressure hovering around 88, 92, 94, and they are ambulatory without any reported hypotensive symptom. And they are treatment naive, kind of de novo. How would you proceed here? You very like you had a liberty to exclude systolic blood pressure below 100 in your trials, but it's a real world scenario. And then there were debates about between you and Dr. Milton Packer about sequencing of the drugs, of the Fantastic Four, which first, in these kind of subsets which are high risk, multi-morbid, multiple structural functional comorbidities, and they are sicker patient with poor LVs and systolic blood pressure 92 and younger people. So
Right.
how would you proceed, sir? This is one. And secondly, sir, somebody has been initiated on say all these 4 drugs, especially sacubitril valsartan and dapagliflozin, at 34 GFR or 36 GFR, quasi 3B, stage 3B CKD, and then he plummets over the months or years to 21 ml, 22 ml. Does it mandate me to stop the therapy? And if I can control potassium, can I continue with it? Those are 2 questions in the sicker patient in Indian scenarios.
2 great
Thank
questions.
Okay, so very good questions again. So the first question, so I obviously encounter exactly those patients as well in my own practice. And by the way, in Paradigm, you could be randomized if your systolic pressure was 95 millimeters of mercury or above. So actually the Pioneer trial had a higher threshold because they were concerned because those were hospitalized patients. So we did actually have patients who had a lower starting blood pressure. So what would I do in the patients that you describe? Well, honestly, what I would do today would be, and in fact, do today. I've seen many patients like that in the past few weeks. I would start them on sacubitril valsartan. I would start them on dapagliflozin and eplerenone. Those are the SGLT2 inhibitors and MRAs that I personally use, but very happy if you use something else. After a week or so, I would start a beta blocker, and after that, I would start sacubitril valsartan. You might ask me why I do it that way. I do it that way because the first two of those treatments, dapagliflozin and eplerenone, have a negligible effect on blood pressure, can be started together. And
Yes, sir.
In some modeling that we did based on our clinical trials, give you the greatest bang for your buck, as my American friends would say, in terms of reducing events. So when Milton and I wrote our first article about this, our speculation was it would be an SGLT2 inhibitor, and beta blocker would be the
Yes, sir.
most effective combination. But actually, when we analyzed the data, real data in people, in trials, it was actually an SGLT2 inhibitor and an MRA was the most effective combination.
Yes.
So it's both effective and well tolerated from a blood pressure perspective. I would then add a beta blocker. In that patient, I would probably use bisoprolol rather than carvedilol, because I think that alpha blocking activity maybe does lower blood pressure a little bit
Yes.
more initially, but generally people will tolerate the treatment. And then I would add sacubitril valsartan. The reason I would delay sacubitril valsartan is it is the one that is going to reduce blood pressure most, and I want the patient to be as optimized, hopefully as well treated as they possibly can be before I start sacubitril valsartan. But I'm not sure that is the right way to do it, but that is the way that I would do it. I would not be in the slightest bit bothered about the blood pressure as a number. So if it's 85, I don't care. But if they're dizzy when they stand up quickly, then
Yes.
I'm
Yes, sir.
concerned. And in terms of renal function, that is a really good question. And again, I wish I'd realized you were going to ask it, because one of the other sets of analyses we've been doing in the past few days is to look at exactly what you're saying, because so many people ask this. What we've been doing, just like that blood pressure analysis I showed you, we've been looking at people who had an EGFR that decreased to below 30. So I can't tell you about 20 exactly, but to below 30 after randomization.
After the initiation, like we didn't start on that.
After initiation, decreased to 30, and those patients still do much better on sacubitril valsartan than
Yes,
they
sir.
do on enalapril. And I must say, again, my own practice is not to get too worried about EGFR if it reduces, but I don't just look at the absolute level that it gets to. I think about the proportional reduction. So if an EGFR goes from above 60 to 20, that's a very different scenario than if it goes from 30 to 20. If it goes from 30 to 20, I'm very happy to live with that, provided, of course, it eventually levels off.
Yes,
But
sir.
if it goes from 60 to 20, that makes me much more nervous. That shouldn't usually happen. And that means that you have to look at your patient, think about other reasons why their kidney functions deteriorated so much. So I think it's not just about levels that you get to, it's also about the proportional reduction. And in the UK, it may surprise you to know that, for example, with SGLT2 inhibitors, we no longer have in the regulatory labeling for the drug any lower EGFR threshold. So I think we're beginning to learn that doctors can use their judgment, and provided you monitor kidney function, as long as you're not driving your patient to the level of EGFR where you'd have to think about dialysis, then it's probably all right if their EGFR wasn't very high to start with. But if you've got a high EGFR that drops by a huge amount, it's a completely different story. That should make you nervous. That should make you pause.
Yes, sir. Thanks, sir. Thank you.
Professor Greenwood, thank you for wonderful talk. Dr. Kamal Sharma here. So again, two similar comments and questions, actually. One, what my colleague Dr. Prashant already mentioned about the low blood pressure subgroup. I mean, in the paradigm HF, the low subgroup was this subgroup which actually benefited more than those who were on the hypertensive side. So what would be your cutoff? Because a lot of times the central aortic pressure may be different from the peripheral pressure. So as long as 100 is fine, but a lot of times, as he was mentioning, we do tend to start it at 90s and above. And secondly, what about the cost effectiveness that people talk about in patients with improved ejection fraction? A lot of times there is a tendency, once ejection fraction improves in a dilated cardiomyopathy, to switch back to ARB. We know that the data actually tells that it's not a good idea, but have we got into a cost-effective analysis of the same? So two questions on the similar line, what Dr. Prashant was asking.
So,
Perfect.
Well, thank you again. So I don't have a magic number for blood pressure, and I truthfully mean that. So if somebody's blood pressure was 80 systolic and they're walking around, they walk into my outpatient clinic, they smile, they shake my hand, they talk to me, and they're okay, I'm fine about that. I don't like symptomatic hypertension. So that is what makes me retreat. That's what makes me back off. And it's you know, if it's occasionally, if somebody stands up quickly, I might live with that. But if somebody's dizzy, frequently lightheaded, and not feeling good, then I'm not going to persist. So it's not the number, because it's not the pressure, it's the perfusion. And I think that's the other important concept. You can have good perfusion at low pressure, particularly when you're on all the drugs that we give to people with heart failure, because essentially you're converting their circulation to a low pressure circuit. So that's the first thing to say. And that's very, very hard to get across. I mean, my biggest enemy are the GPs in the community and the nurses on the wards, because they are trained, it is ingrained in their head that low blood pressure is bad. And of course, that's true. If somebody has a dramatic drop in blood pressure, somebody could be going into shock. It could indeed be very important, but that's completely different than somebody who's warm, well perfused, thinking, talking, and moving around. So it's trying to get that concept across is I think a struggle that we all have. And your second question was about cost effectiveness. Well, cost effectiveness, of course, is very, very healthcare system dependent. So I cannot speak for cost effectiveness in India. What I can tell you, and I used to work for NICE, in fact, I was on one of the committees that assessed new drugs. And in our country, NICE, National Institute of Clinical and Health Excellence, is essentially the payer. So NICE decides whether the National Health Service will pay for treatments. And we're a very cost-constrained country, contrary to popular opinion. But NICE approved sacubitril valsartan. So we had no difficulty getting sacubitril valsartan way back in 2015, because a cost effectiveness analysis of the paradigm heart failure trial using UK health.
So will you switch back to ARB once the patients have improved ejection fraction?
Absolutely not. Absolutely not. because, as you know, the SAV-HF trial was a randomized controlled trial doing that, and about a third of patients had a deterioration either in their symptoms or in their ventricular function. And you and I probably both have had the experience where we've done this because we've been under pressure from our patients to do it. And the tragic result for some of those people is that after they deteriorate and you restart treatment, you cannot get them improved back to where they were. And I think that is that's clinical experience tells you that it's a bad idea. We have randomized evidence telling it's a bad idea, but it is really tragic, particularly in a young patient, because they're often the ones who want to stop treatment, to be left with somebody worse off than they were simply because they wanted to withdraw therapy. So I personally appeal to my patients really not to do that.
I think that's the most important message coming out of this discussion, that not to de-escalate therapies once your ejection fraction is improved. Going to the chat box, we have a few questions from our colleagues in Madurai. One is that, is there any gender difference in response to? Yes.
So, sir, with your permission, can we go to the locations where directly
Sure. Please go ahead. Let them ask. Yeah.
Moderators at that location can raise a question.
Yeah, you can start, Rishikesh.
Yeah. Thank you, sir.
Good evening, sir. Excellent lecture.
Yeah. So, in the interest of time and
privileged.
adequate, Okay. Yes, ma'am.
Is that mandatory to go for complete hemogram and serum iron studies regularly in patients who are on SAC-1?
So I measure ferritin and transferrin saturation in all of my patients with heart failure and reduced ejection fraction, because I still think that intravenous iron replacement is beneficial in people who are iron deficient. Now, obviously, the Heart-FID trial has made us all, I think, a little bit puzzled and a little bit less certain than we were about that. But I personally do check, and I don't know if sacubitril valsartan leads to depletion of iron stores, but I do know that SGLT2 inhibitors do. So we've published a paper from DAPA-HF showing that SGLT2 inhibitors, by stimulating erythropoiesis, do reduce ferritin and transferrin saturation levels. And that's probably also true for sacubitril valsartan, because we think they probably also enhance erythropoiesis, probably enhance bone marrow function more generally. So I think it is good practice in your patients with heart failure always to make sure that they're not becoming iron deficient, because I think if for nothing else, for no other reason, iron replenishment improves symptoms and quality of life.
And another question is there any gender difference in the response? Females?
Well, that's a very interesting question. So in HFrEF, no. But in HFpEF, we did find a hint of a gender difference, but I don't think it's a true gender difference. What we found was that women seem to get more benefit than men in the patients with an ejection fraction of 45% or above. But actually, I think that is part and parcel, that is intertwined with the ejection fraction interaction, because an ejection fraction of 55% in a man is probably the lower end of the normal ejection fraction range. But in a woman, an ejection fraction of 55% probably means they've got systolic dysfunction, because men and women have a different normal range for ejection fraction. So we think that extra benefit in women compared to men might actually be the same thing as that benefit in people who've got an ejection fraction that's below normal but above 40%, that sort of intermediate, that mildly reduced ejection fraction group, I think women probably benefit to a higher ejection fraction than men, because women have inherently higher ejection fractions than men, which is a well-established scientific fact in many different studies.
Thank you, sir.
Sir, we'll now go to Chennai location. I would request Dr. S. Manoj sir to raise questions on behalf of audience.
Sorry to interrupt. Moderating doctor is Dr. Rajshekhar, sir.
I request sir to ask questions on behalf of audience.
Yeah, it was a wonderful presentation. And from the Professor John, I just like to know that in India, as Dr. Advani told already, a lot of younger heart failure patients to ischemic cardiomyopathy we have. And I like to ask that after angioplasty, after intervention, usually if there is a viable myocardium and if we intervene early, there will be a good improvement in the LV ejection fraction. And few of the patients after angioplasty, even when there is a very small improvement in the ejection fraction, I have found after introducing ARNI, maybe after 2 to 3 months after introducing ARNI, there is a very good improvement in the ejection fraction to the tune of 10 to 15%. That I would like to know, from the professor and other colleagues, what is their experience in seeing the improvement of the ejection fraction from the baseline in post-angioplasty patient after introducing ARNI.
So obviously, the only way that you can show whether a drug improves ejection fraction, particularly in a patient like that, is to do a randomized controlled trial, because we know that in many patients with coronary artery disease, either bypass surgery or percutaneous coronary intervention can lead to an improvement in ventricular function, and indeed, often because many other treatments are changed, you get that. So unless you have a control group, you don't really know whether a change in ejection fraction is due to the drug or whether it's due to other things. We do have at least 2 good randomized trials showing without any doubt that sacubitril/valsartan improves ejection fraction. I'm not aware of any such trial in patients who've undergone angioplasty, but I would say that if you have patients who've required coronary revascularization, who despite that continue to have a reduced ejection fraction, then they are definitely candidates for sacubitril/valsartan, no question about that. We had many patients like that in Paradigm Heart Failure. We've published those data, and whether you've had bypass surgery, whether you've had angioplasty in the past, if you have a persistently low ejection fraction and symptoms of heart failure, then you're better off on sacubitril/valsartan. And my own clinical experience is that many of those people will have a substantial improvement in ejection fraction.
Okay. In few of the patients, I've seen the ejection fraction improvement is up to 10 to 15%, remarkably. That is why
it's good.
So can we go to other locations if there are any questions before we wind it up?
Now we'll go to Surat location. Yeah. So we'll go to Surat location, where I would request Dr. Dhaval Shah sir, who is moderator there, to ask questions on behalf of audience. Dr. Dhaval Shah sir, Surat location.
Dhaval has posted his question here in chat box, and he says that at what EGFR cutoff should we not prescribe ARNI? I think this was already discussed, so maybe we can.
Well, in general, the best patients are those who've got an EGFR above 30. I think we have learnt that you can cautiously, if you're an experienced heart failure physician, and if you monitor your patients carefully and can follow them up closely, then you can use sacubitril/valsartan in patients with an EGFR below 30. But you have to be careful. You have to be responsible when you do that. And I think most of us who've had now many years of practice using sacubitril/valsartan do that, but you do it cautiously and you have to watch carefully. And it's an absolute requirement that you check somebody's EGFR within 1 to 2 weeks of starting sacubitril/valsartan if you start with a very low EGFR. So the general guidance is it's safe above 30 because that's what the trials required. Clinical experience allows us to go a bit lower, but you have to do that carefully and watch.
And sir, how about
patient
those
closely.
patients who are on regular dialysis?
Well, we don't really know. That's what you were asking me actually, I think at the start, or no, somebody else was asking me at the start about that. There are ongoing trials looking at that. There are a couple of case series, I think mainly from China, saying that you can use sacubitril/valsartan safely in these patients. We do it sometimes, but it's an evidence-free zone because we had no dialysis patients in any of the existing randomized trials.
Sure, sir.
Yeah. So we'll.
It's
Yes, sir.
the case I was alluding, so in these outliers and in these exceptional ones, can we do some off-label tips and tricks that are the 50 mg sacubitril/valsartan, half BD or something, some ERNI better than no ERNI in a hypotensive patient or kind of borderline to have them exposure to it and then build it up with all hopeful, fingers crossed, something like that, sir?
So I'm if you're asking me about splitting tablets,
yes, 50 mg. So India, we are working on it.
Yeah, I have no
Subhash,
experience in doing that, and I'm reluctant to say anything about that because I'm always worried that if you split pills, you don't do it accurately, and I'm not sure exactly what it is you get in the two halves of the pill. So I'm afraid I have to not answer that one. In terms of what do we do if we're in that position? So what we often do is just to give sacubitril/valsartan once a day at bedtime and let the patient get used to that before trying to introduce the second dose in the morning. So that's, I suppose, our alternative approach to it. Now, it's not ideal because to get sustained, complete neprilysin inhibition, you definitely need to give the full dose of sacubitril/valsartan twice a day. So obviously, and that's also obviously true for blockade of the angiotensin II type 1 receptor. So you maybe don't get the full benefit. I think at the start we were very uncertain about whether you got worthwhile benefit from lower doses, but I think the Pioneer trial, which I showed you, that trial in hospitalized patients with HFrEF, only 55% of patients were in the full dose. Full dose, yes. Of valsartan, yet there was a very clear benefit. So I think that tells us that you do get worthwhile benefit from lower doses. How low, I don't know. And how do you administer those lower doses? Well, I can only tell you what we do in practice. We don't split pills, but we do often just give people the treatment once a day, try and stagger the drugs to reduce the likelihood of hypotension, because it's usually symptomatic hypotension that is the dose limiting problem.
Yes, sir. Thanks.
So now we'll go to Trichy location. I request Dr. Ganesh sir there, who is moderator, to ask questions on behalf of audience.
Please.
Thank you.
Yes, sir.
It was a very nice and concise presentation, sir. I have two questions. One is patients who are on regular RV treatment who are getting admitted for recurrent heart failure in ICU, how to down titrate or de-escalate and reintroduce what is the timing of RV in such patients? That is the question number one. Question number two is there any indication for RV as a sole treatment for hypertension alone, not in heart failure? Thank you.
Okay, so your first question was about, if I heard it properly, about de-escalating treatment in patients who are admitted to hospital. Well, I think you have to ask, why would you de-escalate treatment? So if somebody had critically poor kidney function, you might de-escalate. If somebody had low blood pressure and you believed that they were hypoperfused, underperfused, you might de-escalate treatment. But those would be the only two reasons you would think about de-escalating treatment. So be very important not to de-escalate treatment just because somebody's got a low blood pressure. But if you have a really good reason to de-escalate treatment, then of course you should do. And as with all of the treatments we use for heart failure, by de-escalating, what you really mean is that either you reduce the dose, which is the preferable option, or if you have to stop the treatment, then obviously you withhold it temporarily and try and reintroduce it. And when you reintroduce it, you have to start at a lower dose and up titrate, as you did when you initially started the treatment. So those are really the points I would make. I mean, the good thing about stopping sacubitril/valsartan because of poor kidney function is that we know that both components of the treatment probably accumulate in renal failure. So even if you stop the drug completely, you're not abruptly withdrawing it. You are effectively reducing the dose, and it's gradually being removed from the patient's system. So often by the time it's completely disappeared from their system, hopefully their kidney function has improved sufficiently for you to restart the treatment. So they've never truly had a period when they're completely off the therapy. And your second question was about hypertension, I believe. Is that correct? And I can maybe show you, if I can share my screen very quickly, some data that I didn't include in my presentation. So I hope you can see my screen. So in the Paragon heart failure trial, I hope you can see it. The Paragon heart failure trial, we actually had a lot of patients with resistant hypertension. So these patients here were patients who were on a diuretic, a calcium channel blocker, a renin-angiotensin system blocker, and were often on other drugs, including, for example, alpha blockers and beta blockers. And you can see here that sacubitril/valsartan, shown in blue, compared to valsartan, shown in red, further reduced blood pressure. But the most intriguing finding was in this group to the right, who were patients who, in addition to all of those drugs, were on a mineralocorticoid receptor antagonist. That was mainly spironolactone, which of course is the first line option for resistant hypertension. Even in people getting an MRA on top of all of those other drugs, you can see that sacubitril/valsartan really substantially reduced blood pressure further. So in patients with resistant hypertension, sacubitril/valsartan actually seems to be a very effective treatment. And that paper is published in the European Heart Journal.
With Dr. Subhash Chandra sir's permission, can we take one or two questions from the virtual platform? where audience have
Maybe
shared
that
questions.
didn't share. Sorry.
I think we have discussed most of the aspects regarding this novel molecule, and I think we need to seek permission from Professor John if he agrees to. Yeah, these were the slides which he was trying to show us.
Yeah, sorry, I apologize that didn't show.
Yeah,
So
please
here,
go.
here you can see those two groups at the bottom of the slide.
So that sounds good. So it has a hope in future for hypertensive and especially resistant hypertension patient. And there's some data which shows that compared to ARVs, if you give this drug to hypertensive patient, it achieves much better control and pressure.
It definitely lowers blood pressure more. I mean, it's a double-edged sword. That's why that's potentially a problem for us, particularly in patients with HFrEF, but it's also why this is another indication in certain parts of the world for this particular drug. In fact, sacubitril valsartan in Japan, for example, is approved as a treatment for hypertension.
Oh, wow. And there's some evidence creeping in atherosclerosis where it could be a drug for plaque stabilization.
I'm not going to say too much about that. I mean, maybe. So one of the interesting things we found in the Paradise MI trial, our post-infarct trial, was that although we did not come up with a convincing significant reduction in heart failure hospitalization, there was a significant reduction in coronary events. Now, that was a secondary endpoint, and I don't want to make too much of it, but it was an intriguing finding.
Okay. Great. So, Rishikesh, should we wind it up now? Extensive section, yeah.
Yeah, there was only one question from audience, like if you're with your permission and Professor McMurray's permission.
Please.
Last question, sir.
Please read it out.
Yeah. So the question is, given that iron deficiency is so prevalent in heart failure, and also the IV iron therapy has been found to be beneficial in HF patients.
Yeah.
So do you think that IV iron therapy is underutilized in
this
heart
has
failure management?
been answered, yeah. Yeah, please, maybe a repetition of the answer.
So we up until a few weeks ago, we would have said definitely yes, but I think this large trial called Heart-FID has raised some questions about that because it did not confirm the reduction in heart failure hospitalization that we'd seen in other trials. Now, there may be reasons for that, and there are additional analyses going on, but my own interpretation, for what it's worth, of that trial is that the problem was that there was not redosing. So while there was an early benefit, that was not sustained in the long term. But I think that's simply because people did not give repeat infusions of intravenous iron. So I, as I said earlier, do check TSAT and ferritin all the time in my patients with heart failure and reduced ejection fraction, and I do treat it with intravenous iron therapy.
Yeah, the same thing is here. And the very fact that this trial was a little flawed because it was conducted during the COVID times.
Yeah, that was the other problem.
So I think we should continue estimating ferritin and saturations, despite being a normal hemoglobin. And we continue to do that, to repeat these shots every 6 months so as to accrue symptomatic benefit in these patients. We continue.
Agree.
Thank you so much, sir, for your extensive elaboration on the knowledge about this molecule. And we are truly indebted to you and express our gratitude for being with us for almost 2 hours now. And we hope to see you someday soon and listen to you in some meeting. Thank you very much, sir.
Thank you. Bye-bye.
Thank you. Good night.
Bye, everybody.
Thank you, sir, for your closing remarks. So we are nearly at the finish line. So let's express gratitude to all who made this speaker program possible. I extend my deepest gratitude to our distinguished speaker, Professor John McMurray, sir, for his insightful presentation. Your contribution has undoubtedly expanded our understanding pertaining to ARNI usage in real-life clinical scenario. I would like to express my sincere gratitude to our esteemed national moderator, Dr. Subhash Chandra, sir. and expert panelists, Dr. Kamal Sharma sir and Dr. Prashant Advani sir, for sharing their research, knowledge, and expertise with us today. I am also grateful to all the respected moderators at various locations for active participation and deliberation. I would also like to thank our esteemed audience at physical locations and on virtual platform for their active engagement and for making this symposium a resounding success. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at Emcure who have contributed to this program's success. So let's carry this knowledge into our practices, research, advocacy, and fostering a healthier future for those with heart failure. Thank you once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thanks, Rishikesh. Good
Bye,
night.
Subhash. Good night.
Thank you, sir.
Bye,
Bye.
bye,
Good
bye,
night,
Dr.
everyone.
Bye, Dr. Damdeep.
Yes, good night, sir. Good night.
Bye, everyone. Bye-bye.
Good night, sir.
Bye.